We are going to discuss rheumatoid arthritis. Rheumatoid arthritis is a chronic systemic inflammatory disorder that is characterized by potentially deforming polyarthritis and a wide spectrum of extraarticular manifestations. So we have progressive joint destruction and deformity, and as we said, the main important points is the chronicity, the inflammatory process, the polyarthritis, and presence of extra-articular manifestations. When we go to the etiology, we should know that it's an autoimmune disease and the cause seems to be interplay between different factors like the genetic susceptibility, the environmental influences, and advancing age. The main important genetic factors is the presence of the HALA-DRB1 gene, which is contribute to the 50 or 60% of the risk of developing rheumatoid arthritis. The female sex hormones also play an important role in the development of rheumatoid arthritis. Estrogen is known to stimulate the immune system, and deficiency of vitamin D also can be associated with rheumatoid arthritis. If we revise the anatomy of the synovial joint, we can find the external fibrous capsule for protection of the synovial joint, which is lined by the synovial membrane. This synovial cavity is filled with the synovial fluid and lined with the synovial membrane. The bones are separated from the synovial cavity with the cartilage. So the bluish color here is the cartilage, while the greenish is the synovial membrane, and the cavity, as we said, is filled with the synovial fluid. If we see here, we can see the pathogenesis of rheumatoid arthritis, which is started by an etiological factor which is not well understood or identified, but it can be due to infection by certain microbes. Then the antigen presenting cells are going to present this antigen through the major histocompatibility type 2. Then this is going to induce the activation of or a release of the cytokines like the tumor necrosis factor by the CD4 T cells. Then this cytokines is going to do different functions. They are going to act on the endothelial cells in order to result in expression of more adhesion molecules necessary for the inflammation process, and this is going to result in more accumulation of inflammatory cells at the site of the inflammation. Also, the tumor necrosis factor or cytokines, they are going to activate the B cells, resulting in formation of plasma cells, and these plasma cells are going to release the antibodies like rheumatoid factor and other antibodies. This is going to form immune complex and result in deposition of this immune complex at the site of injury, which is the joint. And also here in the other pathway, we can see that the tumor necrosis factor is going to act on the macrophages, results in activation of macrophages. The activated macrophages are going to release more inflammatory mediators like the tumor necrosis factor and interleukin-1. This is going to stimulate the proliferation of cells like the fibroblast, the chondrocytes, and the synovial cells. And this proliferation is very important for the formation of bonus. Also, the macrophage activation directly is going to release certain enzymes can act or having a role in destruction of the joints like the stromycin enzymes. And all this at the end is going to result in the process of the bonus formation. The bonus formation is destroying the bone and the cartilage, and also this can be followed by the process of fibrosis and ankylosis. The affected joints are showing chronic synovitis. So the main lesion here is chronic synovitis. As we said, the bonus is formed by the proliferating synovial lining cells admixed with inflammatory cells and granulation tissue and fibrous connective tissue. Now here in this slide, we can see the rheumatoid arthritis effect on the joint in comparison with normal joint. Here we can see the proliferation and the proliferation of the synovial membrane cells, and also the proliferation of the fibroblasts and the inflammatory cells like the dendritic cells, plasma cells, and B cells, and also proliferation and formation of the granulation tissue with extensive angiogenesis and blood vessels formation. All this is going to result, as we said, in the bonus formation. We call all this the bonus formation. Now, what is the other effects of this inflammatory process is, as we said, it can be only synovitis, inflammation in the synovium, or fibrous can be more complicated to form fibrous ankylosis. What we mean by fibrous ankylosis? Ankylosis means fusion. The proliferation of the fibroblast is going at the end to form fibrous ankylosis. Also, this fibrous ankylosis can be complicated by bony ankylosis, and this is why in case of bony ankylosis there is complete fusion of the bones and resulting in the formation of the deformity. So here at the first picture we have normal joints, while in the second picture we can notice here the synovitis and the bonus formation, and here we can see the fibrous ankylosis followed by complete fusion of the bones and formation of bony ankylosis. At the end, the complication can be in the bone as being very weak osteoporotic bones. Now, what are the signs and symptoms of rheumatoid arthritis? They are variable course of exacerbations and remissions. So the patient condition is going to be relapsing and remitting. The most important clinical manifestation is the morning stiffness, because the morning stiffness duration is characterizing rheumatoid arthritis. It should exceed 1 hour. So the 1 hour morning stiffness is very important for the diagnosis. And this stiffness is going to improve with the use of the joint, and it is worsen with the rest. This is very important to identify some differences between the rheumatoid arthritis and osteoarthritis. The duration of stiffness in the morning is important. Also, the occurrence of polyarthritis, because symmetrical joint involvement with tenderness and swallowing and the affection of the small joints is mostly common, occurring in the hands and feet, in the metacarpopharyngeal joints and the proximal interpharyngeal joints and metatarsophrynggeal joints. So mainly the disease is affecting the small joints, and as we said, it is symmetrical process, so it is going to affect both sides, the right and the left. Constitutional symptoms can occur like profounding fatigability, depression, myalgia, and weight loss. And the most important issue here is the presence of extra-articular manifestations. The limitation of function and decrease in global function status also can occur in patients with rheumatoid arthritis. Now, what are the complications for this chronic synovitis? There is signs of mechanical damage and loss of motion and instability, deformity and crepitus occurrence, and the joint deformities. The most important joint deformities, or the most common ones, like the swan neck deformity or the boutonniere deformity. Also, ulnar deviation and subluxation of the metacarpopharyngeal and radial deviation of the wrist joint. The hammer toe and the mallet toe and the claw toe, all these are deformities that can be commonly encountered in rheumatoid arthritis. Flexion contractures also can be occurred. One of the important complications or the serious deformities problems is the atlantoaxial and subluxation, subaxial subluxation, because here in this case we will have a C-spine or cervical spine instability, and if the patient is having cervical spine instability, there will be neurological impairment and long track signs. What are the long track signs that can be present in patient with subaxial subluxation? Like what? Like spasticity, hyperreflexia, and absence reflexes also. So here we have difficult or dangerous intubation. This is very important point, because the Preoperative precautions in patients who are having multi-deformities or very severe rheumatoid arthritis and many deformities. Before going for operation, we need to know that this patient should have X-ray, C-spine X-ray, in order to avoid the complication of the dangerous intubation. This risk worsening the subluxation and damage can result in damage into the spinal cord. Another thing that is the limited shoulder mobility resulting in spontaneous tear of the rotator cuff, which is leading to chronic spasm. So here we should also put in our mind the complication affecting the rotator cuff muscles. The tenosynovitis also can result in rupture of tendons, and in addition to the presence of carpal tunnel syndrome or the possibility of carpal tunnel syndrome among patients who are having rheumatoid arthritis. Ruptured Baker cyst or outpushing of synovium behind the knee can be the presenting symptoms, which is similar to acute deep vein thrombosis. So we need to differentiate the occurrence of Baker cyst, which can develop rupturing, which presenting with tenderness, hotness, and the same features similar to the DVT. So we need to exclude ruptured Baker cyst. Poor prognostic factors for rheumatoid arthritis including younger age of onset, high rheumatoid factor titer, elevated ESR, and activity of more than 20 joints. So if the rheumatoid arthritis affecting more than 20 joints, and if there is extra-articular manifestations, all these are considered poor prognostic features. So we need to know the poor prognostic features for rheumatoid arthritis. Let's see in this picture the affection of the small joints of the hand and feet affected, which is affected first, and later in complicated cases the large joints may be affected. Here we can notice the nodules and deformities in the upper limb, and in X-ray we can notice the periarticular osteopenia. So we can notice clear osteopenia in this patient. Also we have marginal erosions. If we look to the bone very closely, we can see also some marginal erosions. Now, what is the most important common presentation? As we said, the morning stiffness for more than 1 hour, which improves with use, the symmetrical joint involvement, and the initial involvement of the small joints of hands and feet, plus the constitutional symptoms. This is the most important common presentation. In this picture, we can see the deformities that is occurring due to rheumatoid arthritis, like the boutonniere deformity, the swan neck, the claw toe, the hammer toe, and the mallet toe. It is very characteristic for rheumatoid arthritis. Another presentation can be as subcutaneous nodules. We can notice here in the extensor surfaces, we can see these nodules presenting as subcutaneous nodules of rheumatoid arthritis. And if we took biopsy from these areas, we can notice that we have the nodules, the rheumatoid nodules in their histology. Now, what are the investigations we are going to do for rheumatoid arthritis? We will start with the blood work. In rheumatoid arthritis, the rheumatoid factor is positive in some patients, in most of the patients, because it is 80% sensitivity, but the problem that it is not specific. So it is very common among patients with rheumatoid factor, but the problem that it is not specific because it may not present at onset of symptoms. So we cannot rely very much on rheumatoid factor for the diagnosis, and levels do not correlate with the severity of the disease or the disease activity. This is the problems with the rheumatoid factor. It can be associated with more erosions and more extra-articular manifestations and worse function. The best is the anti-CCB. the anti-citrullinated peptide. It is 80% sensitivity like the rheumatoid factor, but again, it is more specific. The most important point here is that it is more specific, and the specificity here can reach 49% or 94% or 98%, and may precede onset of symptoms. So it is very good in the diagnosis. So here, before the appearance of the symptoms, we can detect the anti-citrullinated peptide. Also, the increased disease activity is associated with decreased hemoglobin. Among patients, we can notice the anemia of chronic disease, and also the increasement in the platelets, ESR, and the C-reactive protein as an inflammatory process. When we do imaging, we are finished from the blood work, we go to the imaging. We can do it for bilateral hands because it is symmetrical symmetrical process. We should check for the wrists, for the ankles by X-ray. First change is the periarticular osteopenia. As we said, this is going to be followed by presence of erosions. We need to do C-spine X-ray, may be normal at the beginning of the disease, but it is required and very important for pre-operative assessment in long-standing disease. This is very crucial. Ultrasound with power Doppler is often changes of synovitis or erosion noted in advance of this seen on plain X-ray. We are going for the MRI if we needed to use for image hands to detect early synovitis and erosion, so it can give us early diagnosis of these complications. MRI T1 is inflamed synovium, is hypotense in MRI, and hypertense on T2. Bone marrow edema can seen as well at the areas with increased uptake of gadolinium contrast. This is how we can see the changes in MRI. Now, how we can go for the diagnosis? Before we do the diagnosis, which is clinical diagnosis, we need to do scoring for the patients. The scoring of the patients should be relying on what? First, on the joint involvement. Mainly, it likes the small joints, so we are going to give 5 for affection of more than 10 small joints, and we are going to give 0 for affection of 1 large joint. If it's affecting from 2 to 10 large joints, then we are going to give the score of 1, and if it is affecting from 1 to 3 small joints, we will give the score of 2. Score of 3 is given in affection of 4 to 10 small joints. So here we are going to give the scoring according to the number of the joints affected. The second feature in the scoring is according to the serology. If the patient is negative for rheumatoid factor and anti-CCP, then we are going to give 0, and we will give 3 for those who are having high positive rheumatoid factor or high positive anti-CCP, and 2 for those with low positive rheumatoid factor or low positive anti-CCP. The third domain in the scoring is the acute phase reactants. If the patient is positive for C-reactive protein or have increased level of C-reactive protein or abnormal level of ESR, we are going to give 1, but we will give 0 in case of normal C-reactive protein and normal ESR. We said that the disease is a chronic disease, and chronicity is very important for the diagnosis. So if the disease is occurring for less than 6 weeks, then we are going to give the patient 0, while we will score 1 for those who are having the disease for 6 or more weeks. If the patient score 6 or more out of 10, then the patient can be clinically diagnosed as having rheumatoid arthritis. Also, there is other types of scoring systems for disease activity of rheumatoid arthritis, like the DAS or disease activity score, which is dividing the patients after treatment into remission, low activity, moderate, and high activity. And this is in case of scoring less than 2.6, it is remission. From 2.6 to 3.19, this is low disease activity. 3.2 to 5, this is moderate activity, and more than 5.1 are considered having high activity. This is another type of scoring for the disease activity. Now let's have a look on the extra-articular manifestations of rheumatoid arthritis classified under their pathophysiology. Starting with the skin. In the skin, before we go for skin, we can divide them generally according to the pathophysiology into vasculitic events or lymphocytic infiltration event. Those with vasculitic events, like that is occurring in the skin because of the periangle infection, cutaneous ulcers, the palpable purpura, all these are examples of the vasculitic events that can occur in the skin, while rheumatoid nodules formation, which also may have vasculitic component, is the lymphocytic infiltration events. In the eye, the patients are going to have vasculitic events like the episcleritis and the scleritis, while the lymphocytic infiltration event is the keratoconjunctivitis sicca. So also patients are going to have keratoconjunctivitis sicca due to the lymphocytic infiltration. In the head and neck, the patient may present with lymphocytic infiltration resulting in xerostomia and in shape of Hashimoto thyroiditis. In the heart, there is only lymphocytic infiltration pathogenesis resulting in pericarditis or myocarditis or valvular disease, or it can be presented as conduction defects. All this the extra-articular manifestations here are due to lymphocytic infiltration pathogenesis. In the lung, they can be presented as pulmonary fibrosis, pleural effusions, and pleurocytis, and even the formation of the pulmonary nodules. All of this, as we said, due to lymphocytic infiltration. In the CNS, the vasculitic event or the vasculitic pathogenesis are causing peripheral neuropathy. Patients are going to present by sensory stocking gloves. Mononeuritis multiplex also can be presented. The hematological process or the hematological system can be presented by splenomegaly or neutropenia as a part of Felt syndrome. All of these are going to be due to the lymphocytic infiltration pathogenesis. In the kidney, the process is going to occur is the amyloidosis and deposition of amyloid protein caused by accumulation of this abnormal protein called amyloid. Just let me remind you that in case of pulmonary extraarticular manifestation, the pleural effusion here is very characteristically having virulent yellow to green color. This is very characterizing for the pleural effusion due to rheumatoid arthritis. Now, an important point we need to put in our mind: what are the syndromes that is associated with rheumatoid arthritis? We have the SS, which is common. This is Sjogren syndrome, which is composed of keratoconjunctivitis sicca and xerostomia. So the patients are going to have dry eyes and mouth. Another important syndrome is the Kaplan syndrome, although it's rare, but you should put it in your mind because there is combination of rheumatoid arthritis and pneumoconiosis that is as manifested as multiple intrapulmonary nodules. So if we find a patient with multiple intrapulmonary nodules and pneumoconiosis, causing pneumoconiosis, plus rheumatoid arthritis, we can diagnose it as Kaplan syndrome. In addition to this rare syndrome, we have also the Felt syndrome, which is the combination of arthritis, splenomegaly, and neutropenia. So any patient with arthritis, splenomegaly, and neutropenia, this most probably a Felt syndrome. Now we go for the treatment. The main goal of the treatment is to make the patient in the remission state and also lowering the possible disease activity in order to decrease the complications. The key is early diagnosis. So in order to have good prognosis, we need to do early diagnosis and early intervention with the with the disease-modified anti-rheumatoid arthritis drugs. The window of opportunity, this is the early treatment within the first 3 months of the disease. This is going to result in better control and remission. We need to assess the poor prognostic factors at the baseline. We need to check for the rheumatoid factor positivity. We need to check for the degree of dysfunctioning or deformities, the functional limitations, and we need to assess the presence of extra-articular manifestations. This is the goal of the therapy. Now we start with the behavioral therapy. We need to involve the patient into exercise program to stay active and to do gentle range of motion and isometric exercise during the duration of flares, like doing aquatic and aerobic exercises, strengthening the exercise. We need to do strengthening exercise between the time of flare. So during the flare period, we are going to do gentle range of motion and isometric exercise, and we are going to do more strong exercises to strengthen the muscles and the joints in between the flares. Patients also should change their job if it is needing more usage of the joints, like for example can be helped this by helping them by using assistive devices as necessary, either to modify the job or change the job if necessary. Interventions to reduce the cardiovascular diseases like by doing smoking cessation and by doing lipid control. So we need also to reduce the risk of cardiovascular diseases among these patients by behavioral therapy, stopping smoking or controlling their lipids. Then we are going for the pharmacologic diseases, and the aim of the pharmacologic treatment. And the aim of pharmacologic treatment here is to alter the disease progression. We need to stop the occurrence of complication. The disease-modify anti-rheumatic drugs and the biologic, which is not analgesics or non-steroidal anti-inflammatory drugs, this can alter the course of rheumatoid arthritis. The disease-modified anti-rheumatoid drugs treatment with these drugs should be started, as we said, as soon as possible after the diagnosis is made, and the aim is to make the patient at a remission phase. Methotrexate is the gold standard, and this is the first line of therapy unless there is any contraindication for the usage of methotrexate. Prior to methotrexate therapy, we need to check for the CBC. We are going to assess the CBC to check for the liver enzymes, mainly the ALT, and we check for the liver function test by doing creatinine clearance and screening the patients for hepatitis B and C by doing serology plus doing chest x-ray before we are going to use the methotrexate. This is baseline investigations we need to do. Monitor, and if inadequate response after 3 to 6 months, then we are going to use combination therapy. We are going to add to the methotrexate another line of therapy, or we need to change. Consider combination therapy to the methotrexate in patients who are having poor prognostic features or high disease activity. So in patients who we are considering them high risk or high disease activity or poor prognostic patients, we are going to consider the combination therapy. Therapies include hydroxychloroquine, the sulfasalazine, leflunomide, and the biologics. If there is any contraindication for the methotrexate, then the hydroxychloroquine and the sulfasalazine and or the leflunomide should be considered, with the consideration that the hydroxychloroquine is weaker than the sulfasalazine and the leflunomide as options. Now the biologics. The biologics, this should be used if there is inadequate response to the drugs to the disease modifying anti-rheumatoid drugs, and in this case we should combine the disease modified anti-rheumatoid drugs therapy, initiating with the combination of therapy is associated with the faster response rate and longer duration effect. So the combination is the better option. First line, we have first line options like the anti-tumor necrosis factor, for example, like the infliximab, the interacept, the adalimumab, the golimumab, and the certolizumab. All these are anti-tumor necrosis factor. There are non-anti-tumor necrosis factor agents, including the anakinra, almost never been used for rheumatoid arthritis. Also the abatacept, the rituximab, and the tocilizumab also are non-anti-tumor necrosis factor agents. We need to reassess the patient every 3 to 6 months and monitor them for the disease activity, predominantly by assessing the swollen joint count, how many swollen joints the patient is having. The tofacitinib, the JAK inhibitor or the tofacitinib, this is a technically synthetic disease-modifying anti-rheumatoid drug that is used if the other drugs are failing for treatment. This about the biologics. Now, what is the pharmacological options we can add to support or reduce the inflammation and pain? We can add the non-steroidal anti-inflammatory drugs as individualized according to their efficacy, tolerability, and comorbidities. So it differs, the choice is differing according to the patient's condition. It can be sometimes contraindicated or used in caution with some patients, like those who are having peptic ulcer disease or ischemic cardiac disease, or pregnant patients, or among those with chronic kidney disease, or with those who are using anticoagulants. We can add acetaminophen for synergistic effect of the pain control. In addition to this non-steroid anti-inflammatory drugs, also we can add the corticosteroids. The corticosteroids can be used locally as local injections in order to reduce the symptoms of a specific joint, or can be used as systemic option like taking oral prednisolone or intramuscularly in low doses for like 5 to 10 milligram. Useful this for short term to improvement of the symptoms if the non-steroidal anti-inflammatory drugs are not effective, or even to bridge the gap until the disease modifying anti-rheumatic drugs are taking their effect. Also, in this case, we need to check before we give the patients the steroids or prednisolone. We need to do DEXA for the bone density in order to make sure that the patient is not at risk of getting osteoporosis. And also, in addition, we may need to add the bisphosphonate if we need larger doses of corticosteroid. So if the dose of corticosteroid is increased till it reaches 7.5 for more than 3 months, then we need to add the bisphosphonate for treatment or avoidance of osteoporosis. In addition to this, we need to put some caution for the contraindications like the active infection or the presence of tuberculosis, previous history or diagnosis of osteoporosis, hypertension or gastric ulcer, or diabetes mellitus, which are all considered contraindications for the use of corticosteroid. The surgical options of treatment is indicated if the patient is having certain deformities or structural joint damage, and here the patient surgical options like doing synovectomy, joint replacement, or joint fusion, reconstruction, and tendon repair processes. If you like the video, please subscribe to my channel and press the like button, and let me see you again in next videos. Thank you very much.